Good afternoon, and welcome to the Institute for Medicaid Innovation's webinar, Millions of Children May Lose Medicaid. What can providers, health plans, states, and consumers do? I am Andrea McGlynn, the Health Policy and Program Associate at the Institute for Medicaid Innovation. Before we get started, I want to review a few details for today's session, along with some reminders. This webinar will be recorded and archived with all accompanying materials on the IMI website within 1 week of this session. Please note that the information presented today on May 6, 2022 will change between now and even next month. Anyone watching this as an archived recording should check updated resources and links. Today's session will include an introduction, presentation, panel discussion, and a Q&A session for you to ask questions of our guest speakers and panelists. To ask a question, please use the Q&A feature on Zoom at any point during the session. In the event that we receive more questions than we can address within today's webinar, we will provide all questions to today's guests for a written response. We will post FAQs with the webinar materials. At the completion of the session, we will put in the chat box a link to complete a short 3-minute feedback survey. Please give us your feedback. We encourage everyone to live tweet today's session. Follow IMI on Twitter to be connected to the handles of all the speakers and panelists. Our Twitter handle is on the bottom right-hand corner of the slide. Now, let's get started with today's session. I am excited to introduce our session moderator, Dr. Sandra Hassink. Dr. Hassink is the chair of the IMI Child and Adolescent Health Subcommittee and a member of the IMI National Advisory Board. She is a past board member and the past president of the American Academy of Pediatrics.
Thank you for your introduction, Andrea. And I really look forward to spending the next hour with everyone as we discuss strategies to support ongoing Medicaid coverage for children as the public health emergency period ends. I'm going to provide a brief background on IMI and the topic of our webinar. Then I'll introduce our speakers. The Institute for Medicaid Innovation is a national 501c3 nonprofit, nonpartisan research and policy organization located in Washington, D.C., charged with leading scientific and policy initiatives that produce objective resources while supporting implementation efforts to scale up promising best practices and innovative initiatives. As noted on this slide, the mission of IMI is to improve the lives of Medicaid enrollees through the development, implementation, and diffusion of innovative and evidence-based models of care that promote quality, value, equity, and the engagement of individuals, families, and communities. IMI's Child and Adolescent Subcommittee is committed to advancing the health of children and adolescents by reducing health disparities, strengthening the foundations of health, and responding to the unique circumstances that challenge the health and well-being of children and adolescents. This is the first of our planned series of webinars for 2022. Each are aligned with IMI's strategic priorities, with an emphasis throughout on community and equity. To provide some background on the importance of this topic for children enrolled in Medicaid, here are a few key facts from the report we will be exploring in today's presentation. As of June 2021, over 40 million children were enrolled in Medicaid or CHIP for their health insurance, the vast majority in Medicaid. From the month prior to the pandemic in February 2020, through June 2021, children's enrollment increased by 11%. Now, about half the nation's children are covered by Medicaid or CHIP. These statistics are a brief update on the state of children's health in the U.S., realities that have been with us for a long time and have been exacerbated by the COVID pandemic. In light of the health issues affecting so many children and the number of children covered by Medicaid, it's clear that maintaining coverage to what we should view as the main health insurance for children will benefit millions of children and their families. Now that we have some background information on this topic, I'm delighted to introduce our presenters. My colleague Sarah Holbert placed the link in the chat box to view full bios for each of our presenters and panelists. Joan Alker is a nationally recognized expert on Medicaid and the Children's Health Insurance Program, and is the lead author of an annual report on children's health care coverage trends. Tricia Brooks focuses on Medicaid and CHIP eligibility and enrollment policy, program administration, and the quality of health care. Welcome, Joan and Tricia. Your February 2022 report, Millions of Children May Lose Medicaid, What Can Be Done to Help Prevent Them from Becoming Uninsured, served as an alarm bell, but also as a very helpful roadmap for Medicaid stakeholders. We thank you very much for joining us today to share more.
Thank you, Sandy, and thanks so much to IMI for hosting this webinar. We can go to our first slide. So I'm going to talk to you today about, start with why did we write this report and why is it so important? You know, we find ourselves, and I know we all feel this almost every day, that we're living history. This is a very unique period of time. It's a moment of change in our country and around the world. And we find ourselves in a set of unprecedented public policy circumstances that really could have an enormous impact on children. And we're going to talk about this some more. But essentially in our report, we estimated, and we actually believe this is a conservative estimate, that as many as 6.7 million children could lose their coverage when the pandemic public health emergency lifts. And I'm going to explain why that is. But just to give you a context of the stakes here, in 2019, the last year that we have data from the Census Bureau's American Community Survey, there were 4.4 million uninsured children. So 6.7 is a huge number. So let's talk about why that might happen. Go to the next slide, please. So this again is something that happens pretty much anytime the country's been in recession in the past 20 years. Congress tends to put more money into the Medicaid program. Medicaid funding tends to be countercyclical in that way. So as has happened before in the last few recessions, when the pandemic hit and the recession hit, Congress responded in the Families First Act, one of the COVID relief bills. They put an additional 6.2 percentage points in states matching federal Medicaid match. Also, that resulted in a 4.34% increase in the CHIP match. So states got considerably more federal funding for those programs. Now, in return, states are always asked to do what is called a maintenance of effort, and that is where they must maintain their eligibility levels. They can't make it harder for folks on med enroll. And that's very common. That happens all the time because Congress wouldn't want to give states money and then they just cut their program and pocket the difference. But because we were in a pandemic, there was an additional feature added to this maintenance of effort that we've seen in the past. And that was that states had to keep everybody on Medicaid continuously enrolled through the duration of the public health emergency. So that was the new feature, part of the Families First Act, which was passed by Congress and signed by President Trump. So now we find ourselves moving, hopefully, towards the end of the pandemic. I don't think we're quite there yet. But the question arises, what's going to happen when that continuous coverage comes to an end? And just again, to underscore how high stakes this is the most significant enrollment event in Medicaid since the ACA. And what happens to children and everybody on Medicaid, this is not just about children, we're focusing on children today, but really with respect to children is going to come down to how states, state policymakers, and other stakeholders in the state respond to this situation. Let's go to the next slide, please. So here you see what's happened to Medicaid enrollment since the pandemic hit and the beginning of the maintenance of effort provision. We have now a record number of people on Medicaid, a record number of children on Medicaid, over 80 million people now on Medicaid. That's significantly bigger than Medicare. And as you heard, about half the children in the country, we believe, are now on Medicaid. And I should add that While we don't have detailed demographics on these children, we know that children of color, Black and Latino children, rely on Medicaid disproportionately. So it's surely well more than half of Black and Latino children today are getting their health insurance through Medicaid. Next slide, please. So what we did is we came up with an estimate of which children are protected by this maintenance of effort, the continuous coverage provision I mentioned. It's a little bit confusing for children because CHIP actually, the continuous coverage provision doesn't apply to separate CHIP programs. Now, I'm sure a lot of you are well aware of the complexity of CHIP, but in short, states can either use their CHIP funds to expand their Medicaid program, that's called an M-CHIP program, or they can set up a separate CHIP program. And for those children in the separate CHIP program, which as you can see here from the pie is a relatively small number, they're not protected by the continuous coverage provision. But the children who are in Medicaid funded CHIP, and of course, the vast majority of children are in Medicaid, they're all protected by this continuous coverage provision. Let's move to the next slide, please. So here's sort of a summary of what's going to happen, and then I'm going to break this down in a couple more slides. So as I mentioned, we've got about half the children in the US now, they're getting their health insurance this way. Their coverage has been continuous. We haven't seen any gaps in coverage, which is terrific because this is a common problem for low-income children, that they have gaps in coverage, particularly for Black and Latino children. They haven't had that during this pandemic. That's one thing parents have not had to worry about. They haven't had to go through the renewal process. And typically we see a lot of red tape losses. But when the public health emergency lifts, all of those children and everybody on Medicaid is going to have their eligibility checked. And that is a major, major task. And we know some children will lose coverage in that process. That's how we got to our estimate. Next slide, please. So when is the public health emergency going to end? And as we call it, the unwinding of this continuous coverage provision, when is that process going to start? Well, that's the $64,000 question everybody would like to know the answer to. Right now, this is a declaration made by Secretary Becerra, the Federal Secretary of HHS. And he has extended the public health emergency to July 15th. It operates in 90-day increments. So the Biden administration, however, has promised states that they will give them 60 days of advance notice if they plan to lift the public health emergency. So May 16th is coming right up, and that's a big day because that's when the Biden administration would have to give this 60 days advance notice. So if they don't give the notice, that means they're going to extend the PHE for another 90 days, bringing us to October. Now, that's the most likely way that the PHE will end, but there are two other ways that could impact the end of the public health emergency. The first way is that Congress could actually act to lift this Medicaid continuous coverage protection on a date certain. And they actually did that. The House did that when they passed the Build Back Better bill. And of course, that was some time ago now. So we won't go into the specifics of what they did because it's outdated, but you get the idea. They can and they might, particularly if the reconciliation bill comes back to life in the Senate, which is possible in the next few weeks. So that's something to keep an eye on. The third way that it could end, and this would really be a state-by-state situation, is that a state could reject that 6.2% FMAP, and then they wouldn't be bound by this continuous coverage provision in that state. Now, we've heard rumors that states might do that. No state has done that, but it's possible as time marches on, if the PHE continues, that a state might choose to do that, and then they could begin this unwinding process. Next slide, please. So this is a graphic from our paper, and I'm just going to walk you through the different paths that we think children could be on in this process, and then I'm going to hand it over to Tricia. So first option, okay, children, a lot of children we're talking about here, they successfully complete the renewal process. They are still eligible for Medicaid and they remain eligible and everything's fine. So hopefully that will happen to a lot of children. Next box. Now we have children in families whose income has no doubt gone up since the beginning of the pandemic. They were in families that lost income very quickly when the pandemic hit, and perhaps now they're not eligible for Medicaid anymore. Now, this is where children, it's a little bit different from adults, and that's partly why we focused this report on children, which is, of course, our bailiwick. But for adults, if their income has gone up, they're probably eligible for the marketplace, either the federally run marketplace or a state-based marketplace. So that's a whole different set of issues. But for children, if their income's gone up, most likely they're eligible for CHIP. So that puts it squarely in the state's lap. And then the last possible outcome for children is not a good one at all. It is that they remain eligible for Medicaid, but they're disenrolled for what we call procedural reasons. Tricia will talk more about this, but the family doesn't receive the information about the renewal process, doesn't successfully complete the renewal process. They lose their coverage, even though they're still eligible, and they become uninsured. And this is frankly where we think a lot of these potentially millions of children who become uninsured will fall in this bucket. But essentially, children either remain eligible, everything's good, they remain enrolled, they lose for what we would call red tape reasons, or they're trying to move to a new coverage source. And if we look at that box, most likely it's CHIP. Now, if a state's program is Medicaid CHIP, probably fine because it's the same program. But if it's a state that has a separate CHIP, that's going to be potentially a harder transition. So children in those states may be more at risk. Some children may be transitioning to the marketplace or other insurance, and that may be tricky as well. So you can see here the various barriers that could arise in any of these scenarios. That's why this is such a complicated process. But I want to stress before handing it to Tricia, states can make this work, and there are many, many folks, including people on this webinar, who would like to help to make that happen. And Tricia is going to talk about that. But there is so much at stake here. This needs a really huge effort on the part of all levels of government, stakeholders working together to make sure that we don't lose a lot of children in this process. The stakes are huge, and this is a really unprecedented event, but it is not a predetermined outcome. And we hope that by raising these issues, talking with all of you, that we can all work together to ensure that we don't see millions of children joining the ranks of the uninsured. And with that, I'll hand it to Tricia.
Great, thank you, Joan, and hello, everyone. As Joan said, large numbers of children and families do not have to experience a disruption in coverage if states approach the unwinding thoughtfully and take the time to get it right. But what does that mean? Let's go to the next slide, please. Let's start with balancing the timeline for resuming routine operations with what the workload is and workforce capacity. The workload will be easier to manage if states take the full 12 months that CMS has allowed. The timeline could be shortened in states if they are successful in automatically renewing coverage, but this could lead to an uneven distribution of work in future years. States must also have sufficient staffing to do the work and assist families. But like private employers, states are finding it difficult to retain and recruit new eligibility or call center workers. States risk burning out staff if they are drowning in work, which will only exacerbate their staffing shortages. Renewals should be processed in a timely manner, but this is only possible if eligibility workers can stay on top of the workload. When workers are overwhelmed, mistakes are bound to happen and paperwork may get lost, which simply creates more work. Now, sending reminders and following up with enrollees when information is needed will improve the response rate and reduce procedural disenrollments, but not all states do that. Collaborating with Medicaid stakeholders will not only improve the state's plan, but states will have a cadre of partners who can help amplify key messages and assist eligible enrollees in retaining coverage. Transparency is a fundamental government obligation to share information that promotes accountability. Without understanding the state's plan and being able to monitor key performance metrics, stakeholders can't advocate for mid-course corrections that may be needed to avoid coverage losses. Call centers will function well if wait times are reasonable and staff are adequately trained to provide prompt, accurate consumer assistance that enrollees will definitely need. And keeping the share of procedural disenrollments low is important because historically many individuals lose coverage for non-eligibility related reasons, but they remain eligible and yet they become uninsured. Doing it well also means that children and families who are no longer eligible for Medicaid get the help in transitioning to other coverage sources. Next slide, please. Regardless of what state you're in, state level advocacy is needed. We suggest starting by asking for a seat at the planning table and advocating for these elements that it takes to do this well. Take the time to understand options that states have to promote continuity of coverage and avoid those procedural disenrollments. This includes maximizing available flexibilities that CMS has outlined in guidance and other resources. States should be pressed to share the plan and key monitoring data. In particular, increases in call center wait times or the share of procedural disenrollments are early warning signs that things are not going well. States that are transparent and accountable should be willing to establish a two-way feedback loop that starts with planning and continues through the unwinding period. Intel from the field can supplement those performance metrics to help identify bottlenecks and recurring problems, which should trigger a pause for the state to reassess and refine its procedures and processes. Next slide, please. States should engage a broad array of stakeholders in all phases of the unwinding, from planning to implementation to monitoring. It's obvious that health plans, healthcare providers, Medicaid advisory committees, and navigators and assisters are key partners. But other entities that serve low-income families, including consumer groups, legal services folks, policy advocates, and other community-based organizations, as well as other assistance programs, should be involved. And we should always have enrollees at the table as well. Next slide, please. So it may be helpful to think about the unwinding in phases, because that will determine what needs to be communicated and when. Now, we don't know when the PHE will end, so it's a bit premature to talk about renewals, since continuous coverage actually could remain in place for all of 2022. But now is the time to engage with the state and begin your own internal planning. This is also the time to remind Medicaid enrollees to keep their contact information up to date. Now, once renewals restart, enrollees should be alerted to check their mail and complete their renewal form. But notice the caveat on this slide of if you get one, and that's because some people will be automatically renewed using data available to the state. CMS has confirmed that states may share renewal and disenrollment lists with the MCOs with some limitations to reach out and assist individuals. Health centers and medical offices are often the first to inform patients that their Medicaid has ended. So staff should know how to help an enrollee understand why they lost coverage. Anyone who loses coverage for procedural reasons has 90 days to submit missing forms or information to have their eligibility reconsidered without having to reapply. Those who are determined ineligible may need assistance or referrals to help with transitions to those other coverage sources. States that are accountable will be prepared for a rapid response if things are not going well. However, public attention on recurring problems can often prompt state leaders to take action. So being willing to speak to the media or connect families who are willing to share their stories with organizations that coordinate story collection may be the fastest way to get the attention of state leaders. Next slide, please. So let's get into some specifics of what stakeholders can do now. For the sake of time, this discussion is limited to where we currently are in the unwinding process. Almost all types of stakeholders can be of assistance, albeit in different ways. We've talked a lot about engaging with the state, but organizations should plan what their unique contributions will be and begin to prepare staff. Communications with members, patients, and families you serve is important for all types of organizations, and it's helpful to expand those modes of communications used, including social media and text. Stakeholders should work with the state to review and simplify notices, and familiarity with those notices will also help your staff provide guidance on what next steps an enrollee should take. Some organizations may choose to provide direct consumer assistance, while for others, it will be important to have a list of assistance referral sources, including multilingual assisters and those who serve at-risk communities. Now is also a good time to educate journalists and other stakeholders about the importance of the unwinding to coverage for low-income children and families. We can already see the impact of state and stakeholder outreach campaigns to prompt enrollees to update mailing addresses. But just as providers consistently update contact and insurance information at each encounter, enrollees should be continually reminded to report those changes. CMS has provided temporary flexibilities for states to accept new contact information verified by managed care plans. While this flexibility does not apply to other stakeholders, MCOs can partner with network providers to identify members with new information that can then be verified by the plan. So as you can see, there is a lot to do now and even more as the process moves forward, but with all hands on deck, we can make sure that eligible children and families don't join the ranks of the uninsured. And with that, I think we can turn to our next section of the program.
So thank you. Thank you, Trish and Joan. That was great. And I think I heard the words preparation, 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 and communication, and working together with your partners. So now I'm pleased to welcome our reactant panel. And they're representing perspectives of providers, state Medicaid agencies, and Medicaid health plans, working with Medicaid enrollees and advocates. And we're going to jump right in with our questions for them. So when working with children, a family-based approach is always best. And I'd like to pose my first question to Dr. Arethusa Kirk, Regional Chief Medical Officer at United Healthcare Community and State. Arethusa, in mitigating the risk of children losing Medicaid coverage, how would a Medicaid health plan take a family-based approach?
Thank you, Sandy, and thank you for the presentation. I love those slides, Tricia, and just want to acknowledge for everyone that first, we've been really thinking deeply and planning actively for many months on how to be best poised to respond quickly and agilely to the potential end of the public health emergency for the needs of all of our members, our community, and our state partners. This is really the moment when our partnerships and relationships really matter. And one thing that's come out of the public health emergency for sure has that it's catalyzed us to build those relationships even further. We've been outreaching to our members on a variety of topics to help them navigate through this COVID emergency and public health emergency. And so those points that you brought forward in terms of updating contact information, making sure that they're abreast of changes in the healthcare system have been part of our ongoing strategy. This also highlights really the value of managed care, which is where we work with our state partners on a much regular and close basis to ensure that we're truly meeting the needs of the communities that we serve. We also have a plan for very diverse communications to meet people where they are, understanding that there's a variety of ways in which people ingest information and are able to respond. So we are planning on very direct consumer communications through multiple channels and phases. And our plan is to really to ensure that people feel empowered and educated on their coverage options. We also will be taking the whole family into consideration and understanding that Many people within the family may have a variety of different healthcare coverage. And so looking at that from the ecosystem of the family itself will be very important. And then finally, we really work with our community-based organizations, and particularly our FQHCs, on a regular basis, and have many different consumer channels where we have consumer feedback, community feedback, as well as FQHC partners in a variety of provider advisory committees, as well as large national provider boards that advise us on the work that we do. So from a family-centered approach, we will be targeting organizations that specifically work with children, including our partnerships with FQHCs, as I mentioned, and other organizations like our school-based health centers. So in sum, I would just like to say that we join hands in partnerships with our states, understanding this will be a very large undertaking. And secondly, we will be amplifying the messaging and outreach to the myriad of collaborators that we have in this work. And then finally, we will be taking a broad-based approach to communication methods to make sure that we're truly meeting people where they are and in the communities that they live.
So Arethusa, thank you. Well, thank you so much for that. And I think Trish, did you want to add a few things to those comments?
I just wanted to really emphasize in particular about taking a family-based approach, the fact that parents could lose Medicaid and be confused about their children's ongoing eligibility. And as Joan had mentioned previously, we know that at least 2/3 of the children are expected to still be eligible either for the CHIP-funded Medicaid expansion or the separate CHIP program themselves. So we want to make sure that all stakeholders are aware of that, and we want to make sure that kids stay in Medicaid and CHIP if they are eligible.
So thank you both for that question. And we're hearing themes here of partnership, communication, outreach, and preparation for all of the stakeholders. So thanks for that. Steve Fitton, I'd like to ask you my next question. You were the Medicaid director in the state of Michigan for over 6 years. What opportunities in this report do you recommend that state Medicaid agencies prioritize in their readiness planning? Steve, do you want to unmute?
Yeah, I just noticed
There you
that.
go.
Sorry.
Yeah.
I'll start. Anyway, Joan and Tricia have done a great job in laying this out. And, you know, it does take an affirmative commitment on the part of state government, both the executive branch and legislative support. But given that, and hopefully having a focus on kids as a priority, I mean, really what for me this comes down to has to do with execution. And we all saw how important execution was in the rollout of the exchanges for the Affordable Care Act in terms of trying to bring coverage through that vehicle. And you know, this is another challenge, and it involves IT systems. And Joan and Tricia have pointed out that in their report that fewer than half of the children will be automatically renewed through either IT automatic processes in the IT system or administrative processes. But you need IT systems that are ready to handle this. You need solid administrative processes. You need sufficient and well-trained staff. And then you need the partnerships, which Tricia laid out. And, you know, I would just highlight for the Medicaid agency, the MCOs, the providers, and community organizations, other human services programs and organizations. And I will say that, you know, there is some complexity to this, but it is doable. And we had a very positive rollout of the Medicaid expansion in Michigan, and we actually delayed the implementation by 3 months to be ready. But I think that really does emphasize the importance of timelines and the importance of giving yourself enough time to do what you need to do and do it well and competently.
Thanks, Steve. Trish, anything to add to that?
Yeah, just to reinforce, I mean, we talked a little bit about staffing. Honestly, Texas is 1,000 eligibility workers down out of a 7,000 person workforce. That's the kind of staffing challenges we see, which are going to impact the ability to process renewals, particularly if you end up with a lot of paper-driven ones, and to provide the consumer assistance. So taking the time, being willing to hit the pause button, making sure you have adequate staffing. Those are all key elements that are going to make this go well as opposed to not well.
Thanks a lot, Tricia and Steve. And again, just understanding your processes and Steve, I like what you said about taking time. If you need time, take time to make sure that you've got it working, and then get it rolling. So gaps in Medicaid coverage may lead to, we know, lapses and delays in treatment or preventive care, and that can be detrimental to children's health. And it can lead to more expense when the child resumes treatment of a preventable but now more expensive health problem. And that's a health burden on the child and family, and a cost burden under return coverage by Medicaid or CHIP, or on a provider or county's program for the underinsured. So now I'm interested in exploring the provider's role in this issue. Lindsay Angeles, you're the Chief of Staff at the Children's Hospital of Orange County in Los Angeles, California. Can you share with us some of the things providers can do to support continuous Medicaid coverage for their patients?
Thank you so much, Shandy, and to the Institute of Medicaid Innovation for the time to share the provider perspective. Can't emphasize enough that when we have children with gaps in coverage, it creates vulnerability and it also changes care-seeking behavior. We know, of course, that there are additional emergency department visits that could be avoidable, and it's really not the right and appropriate level of care. We also know that the providers are a trusted source for families, and can be, our pediatricians can be health advocates simply by asking about coverage status at the point of service. And the entire care team, from the receptionist all the way to that pediatrician, can play a role in coverage retention. One thing to note in California we are particularly proud about is we have been leaders in coverage expansion for the family. It is known that if you continue to expand access for families, particularly regardless of immigration status, that does help with children being part of continuous coverage. Can give kudos to our Department of Healthcare Services, our state Medicaid program here, in starting to create a coverage ambassadors program. And foundational to this was having coordinated planning with some helpful public relations experts to have a toolkit, and that included standard language for social media comments about this pending coverage expansion, also standard toolkits in English and Spanish, also, of course, allowing folks to contribute and give their lessons learned from previous efforts to enroll folks. There is a really important thing to note that I'm sure impacts all states, but certainly all of us in Southern California, is that housing instability and change creates challenges in contacting beneficiaries. We are a leader in pre-populating coverage forms with available electronic data in the state to minimize the administrative paperwork. But we know that people have complicated lives. The pandemic disrupted many households. And step one is ensuring that folks, of course, are able to be contacted. We are really, of course, relying on our FQHCs, our CBOs, everywhere at the point of service to have a single amplified message to ensure that we're singing from the same choir book, if you will. And that's where your state Medicaid agency and MCO can play a key role. And we understand that, Oregon and other states do present a little bit more of a leadership model than us in really leaning into that continuous coverage for children, by age.
So Tricia, anything to jump in on that?
You mentioned Oregon. Oregon is hoping to get approval from CMS to cover children continuously up to age 5 or 6. I'm not sure which one, but this concept of multi-year continuous coverage for particularly our youngest children to make sure they get a healthy start is growing. It's not a new idea. It's been out there for quite a while, but we certainly hope that CMS will give a nod to Oregon, and Oregon can be a model for other states. We know Washington State, New York, California, other states are talking about this. I also, we only have about half of the states that are giving 12-month continuous eligibility to children in Medicaid. Some of those states actually give 12-month continuous to higher income children in CHIP, but not in Medicaid. That should be on par. We should advocate for 12-month continuous. And one last point, we cannot measure the quality of care adequately if kids are churning in and out of coverage, because quality measures require continuity of coverage. So this is another prevailing reason, if we really want to improve the quality of care kids get, we need to make sure that they're continuously enrolled.
So thank you, Trish, Lindsay, and Arethusa and Stephen. I just want to jump in because, you know, when you saw that list of things that are chronic conditions of childhood that have been emerging for quite some time, one of the most important things is longitudinal care. Hanging in with that child over time, managing that chronic condition so we don't have multiple exacerbations and remissions. And I think these plans that really look at continuous enrollment and make sure that there are no lapses are critical. And those youngest children, it's so important. Development doesn't stop just because you're not insured. Development goes on, childhood goes on, children acquire conditions, and parents have questions, and they have them continuously, and that should be the way, obviously, coverage should be in my book. So thank you all again, and just stay here because we have questions from the audience. And our first question is, what do we actually know about the state's plan specifically for unwinding? And Trish, I'm kind of looking at you, but anybody can jump in. Trish, you want to take a start at this?
Sure. So each year we work with our friends at the Kaiser Family Foundation on a 50-state survey on Medicaid eligibility, enrollment, and cost sharing. And this year, a lot of the questions focused on how states are preparing. What are they doing to update mailing addresses? Are they planning to boost staff capacity? How long do they plan to take in unwinding? So there's a wealth of information. Now, I can't say that every state answered every question, but I think we were going to drop the link to the survey in the chat so folks can check out what their state is saying compared to other states. The other thing is that we are starting to see a few states releasing their plans. We've seen information from Texas, from Utah. We've heard about some specifics in Idaho. I know Colorado's posting a lot of information. And so the more we really push on this transparency and accountability theme, we will find more and more states releasing the data that we will need to know how they're going to approach things, but also pushing for the data so that we can monitor it as the unwinding begins.
Yeah.
Great. Any other comments about how you get this? Sorry, Joan, go ahead.
I was just going to add a couple of quick points. I think there's a helpful page that CMS has set up that has all of their guidance on the unwinding, as well as the templates that they're asking states to submit. So there's no current requirement that states have to make that data or the report public, but of course we'd like to see that. And so it's helpful though for folks to see what the state's going to have to report. And on that point though, some states I know are talking about a data dashboard that keeps track of what's happening. And I think that would be a great tool to get ahead of. Obviously, would like to see that per eligibility group so we can see how children, adults, others are being affected in different categories. But working now to think about the data and the transparency of that data is critical.
Thanks, Joan. Anybody else want to weigh in on that one? Just a reminder for the participants, if you have questions, please submit them in the Q&A portion of the chat. Next question is, any specific ideas how states or stakeholders can support address updates and redo of paperwork? This gets to, Trish, your manpower questions and about how this is all going to happen, and maybe some of your concerns, Steve. Any specific things we can do to help that along?
It certainly is a communications effort at this point. So any mechanisms that organizations have to reach out to low-income families who are likely to be eligible or enrolled in Medicaid. It would be important just to nudge them to update their information. It's also helpful before you do that to understand the ways that they can do it. Illinois has just posted a secure online form. It's a single link and you just give a few pieces of information and it updates the address. We know that some providers are being alerted in the provider portal to remind patients to update their addresses. But it's really important to know how the state allows it. A lot of states have online accounts for people to report information on their own. It's not, it's a voluntary basis, but there's still a handful of states that don't have these online accounts. They should. So the more that we can maximize the ways that people can get that message, the more likely we are going to update as many people as possible.
Are there any special oh, sorry, Lindsay, go ahead.
Oh, no, just a quick note to add on to that, you know, when you have county coverage determination, it's particularly challenging if folks cross counties. And we know that with less eligibility workers, that can create an undue bottleneck, and where the plans can do electronic verification of housing status from publicly available systems, it's a huge help.
Are there any special considerations for getting children's addresses versus the adults' addresses? If children are maybe in a couple households sharing, you know, one parent, the other parent, are there any things that we should be aware of, or just encourage people to use these general processes?
I was just going to chime in about general processes. You know, this is certainly unable to reach is a real issue for, you know, managed care organizations who are really trying to do their best to outreach all of the membership. And particularly as you brought up quality is a huge, you know, getting people into preventive services. So at every juncture, we've got member services and navigators making sure that we're updating that address information and getting the most correct contact information, and just amplifying how communicating with your state partner to make sure that that information gets durable in the membership files for your state Medicaid partners will really be important. But I think from a consumer standpoint or patients, just amplifying the understanding that it's important to have the most up-to-date information, and that this is where you will be outreached so that you can maintain your coverage, that it's you know, that it's important because it's going to provide you something very valuable.
Great point.
And Sandy, if I can add, it's not just about getting those addresses updated in advance. There's going to be returned mail no matter what we do, no matter how good a job we do, and how states deal with returned mail is going to be important. And that's another thing we highlight in the 50-state survey. Not every state follows up on returned mail other than sending another mailing to the same address, which is likely to yield the same results. So take a look at that, and states that use different communication methods to try to locate someone when they get returned mail, that will be important.
Thanks very much. Next question is, what specific impacts might the unwinding have on children with special health care needs or children with disabilities? What do we need to be aware of for them, or what specific impacts might this have?
You know, Sandy, I'd be happy to jump in on that. I actually worked for almost 20 years in the Children and Youth with Special Healthcare Needs program in Michigan, alongside my Medicaid experience. And, you know, there is a separate Title V funded program through the MCH block grant. So each state has a program that should be focused on that population. They're very different in terms of how they're administered and what the benefits are. Whether it's just to focus on care coordination or actually pay for care. But they do have linkages with the providers who are critical in providing care to this population. And particularly with children with medical complexity, typically there are, you know, very direct connections with specialty providers and often with large specialty hospitals. there actually, I think, because of those connections, is a slightly lower risk of losing those kids in terms of enrollment. But you don't want to de-emphasize it. In fact, I think you want to still emphasize it, because the consequences of losing any of those kids are really significant, as compared to maybe a healthier child. So I think it requires its own point of emphasis, but there are resources that can be singled out, and I think, really focus on that particular part of that particular part of the population in terms of tasking this.
Yeah, thanks, Steve.
This
Yeah,
is Joan. I just want to add a couple points. I think that's a great point, and I'll just mention Family Voices is a terrific organization that works with the families of kids who have serious medical needs. But I think we also need to think about children who are in Medicaid, not based on a disability determination, but are based on an income determination, and may have chronic conditions, right? So we've got, of course, tons of children who have asthma. We've got a lot of children with behavioral health needs. And one place that I think that this is going to show up for families, I think a lot of families aren't going to know they've lost their coverage until they show up either in the pediatrician's office or at the pharmacy. And I just wanted to highlight pharmacies for a minute, because I think they could really be on the front lines of, the parent coming in to renew the child's asthma inhaler prescription, whatever it is. So including the pharmacies, in light of the COVID pandemic, I think there's been a lot more work with pharmacies in the health policy space, which might prove useful to try to think about some of those connections.
Thanks, Joan. Really good point. We have another question about, are there any, there's some concern about children who have parents who have immigrated and might be concerned with giving information or getting information or not sure about it. Anybody making provisions for that particular group of people with that concern?
Yeah, I think that's a great question. I mean, frankly, one of the values and virtues, I think, of the continuous coverage is that families who might have concerns about interacting have had to do so less, right? Remember, this is happening in the context now where we've had a lot of anti-immigrant policies that led to a chilling effect, as we called it, during the Trump administration, where we saw the number of uninsured children go up for the first time in history. I think what it speaks to is really working with community-based organizations, with trusted messengers for those communities. And there's a lot of work going on right now. The Biden administration is redoing the public charge regulation as we speak. So there's some thinking, I think, going on there about how to try to repair the damage. So trying to piggyback on that, but again, it's really about the trusted messengers.
Yes, and developing those partnerships in advance of the unwinding. So we have a minute or two. I'm going to go around and just say any last comments or one thing that you'd most like our audience to walk away with. So Lindsay, I'm going to start with you. Anything you'd like our audience to walk away with from this?
This isn't the focus of this, and additional Institute of Medicaid presentations will, but really lean into the issue on equity, because whatever is challenging for folks who have a certain ability to read and write and navigate in English, let's think about not only Spanish, but even, for example, in California and Ventura County, 40% of our farm workers speak Mixtexo or don't even have a written language. So as much as you can plan early, it accommodates for the needs of the true diversity of our constituency.
Great. Arasuza, what's one thing you'd like people to walk away with?
Well, I would say the thing is that we've got a very strong partnership as MCOs with our state partners, and it's going to require that level of partnership with our state regulators, but all of the aspects of the ecosystem to make sure that we in this healthcare delivery can make sure people stay covered and have information and know their options.
Right. So know your partners and know your network and keep that strong. Steve, what's something you'd like people to walk away with here?
Well, I think just about everything's been said. So what I'm going to say is to my fellow bureaucrats, be prepared. You know, there's nothing like, you know, being prepared, executing well, being competent. And I know that, you know, there's a real dedication on the part of folks that run state Medicaid agencies. And I look forward to them being very successful in all this.
Thank you. Trish, we have a few seconds. Anything you want to just zing the audience with?
Transparency and accountability are going to be key here, and the states hold the cards in many ways.
Okay, and last bullet point to you, Joan. Anything specific you want to say to folks?
Yeah, just to, there's going to be an effort to define this debate as reducing enrollment numbers of inappropriately covered people. This is about children and families. So we have to understand there are children and families behind these numbers, and get out there right now and explain this has been a very positive thing in the pandemic, that parents have not had to worry about their children getting covered, and frame it that way so that everybody understands we have a shared mission here to make sure that we don't see a huge increase in the number of uninsured children. I don't think anybody wants that, but this is going to have to be defined as children and families and non-enrollment numbers.
Absolutely, children in the center. Excuse me. So thank you for all our great panelists and speakers. I really appreciate this, and thanks to everyone for attending IMI's Child and Adolescent Subcommittee's first webinar. A special thank you to our presenters and panelists, and I think we're all walking away with some concrete strategies to help children and their families maintain their healthcare coverage. My colleague Sarah Holbert has placed a link in our chat box to a short 3-minute survey to provide feedback on this session. Please fill that out. We look forward to reading your responses and learning about your interest in future topics. And if you'd like more information on the Institute for Medicaid Innovation, please visit our website, follow us on Twitter, and subscribe to our newsletter. And that concludes our event today. Thank you again for your participation.
Thank you.